Thank you for joining us this morning, Gerry. For everyone listening and checking in, my name is Stephen. I am the host of the Sullivan Healthcare Consulting podcast. I'm a senior management consultant with Sullivan Healthcare Consulting. And today we're going to talk about governance inside a surgical suite and really what that means, what it can do for your organization, and what some of our thoughts are on it as an organization. An expert in that topic here with me today is Mr. Gerry Biala. Gerry, I'd love for you to introduce yourself, give some of your background, and then how you came across Sullivan Healthcare Consulting.
Great, Stephen. Thank you. I am a registered nurse, actually, by background, and I've had a 45-year career focused on care of the patient in the operating room and procedural areas. During the length of that career, I've had an opportunity to be on staff and work very, very closely with patient care delivery in many aspects of perioperative care, including preoperative, intraoperative, and postoperative units. I actually ended up studying perioperative services at a graduate level and have a master's degree with a focus on care of the patient in these areas. I was a clinical researcher very early in my career, but noted that there wasn't a lot of studying going on around the management of resources that we need in delivery of that vital patient care. So I moved my research interest as well as my professional interest over to management of surgical services and have pretty much stayed there. I have been a director of surgical services, both in academic settings as well as community hospitals, focused around researching the things that we do to provide a management of those resources in a better manner for care of the patient in the operating room procedural areas. I transferred over to consulting, which gave me an opportunity to study perioperative services across the country and beyond. That was a great opportunity for me, and am currently working as a senior vice president with Sullivan, with a primary responsibility of oversight on the implementation work that Sullivan does. That's about 70% of the work that we do, and it aligns very nicely with my commitment to studying the management of perioperative services.
That's an incredible background. And just for everyone's that's listening perspective, I worked under Gerry and have on a couple projects, including our current one. And I can attest to the fact that he is one of the most cerebral healthcare workers I have ever come across. And I could say that when it comes from looking at a challenge or an opportunity within a surgical space, I don't think anyone is better than Gerry at looking at it from multiple perspectives and understanding the best way to get to that very center of the spider web that can be a challenge inside a very complex organization. So I'm very glad you're here with us, Gerry. And it sounds like your transition from care provision to the management of care provision is very familiar. I had a crusty old sergeant major once tell me very early on in my military career that one of my primary responsibilities in his formation was to move to friction and reduce it in whatever capacity that was. And it sounds like you in your care provision career, noticed some friction on the management and control side of the house and chose to move towards that and have spent the rest of your career addressing and managing that. So it's something that I think is a great route and something that I align with very closely. So being that expert in perioperative governance, can you tell me a little bit about, what governance inside perioperative services should be doing?
I reflect back on the experiences that I have had as a staff member and as a frontline manager or a director of a department. Very often, it was confusing to me which body I would go to ensure that I could get the right resources in alignment for delivery of that patient care. There were many different committees in the organization. There was a senior administrative structure. What was lacking was a single source that we could go to that understands the care within these areas, and then would also be given the authority, the responsibility, if you will, and the authority to make decisions on managing those resources. So as we were doing the research over the years, we noted a very significant model change in forming executive committees that would then carry the responsibility, accountability, and authority for making decisions on managing resources. And that's where we came about developing the concept of a Perioperative Executive Committee, which is a small body, an administrative committee that is actually given, if you will, not only the responsibility for improving the care within the operating rooms areas, managing the resources, both clinical and support that are needed, And then also the executives and hospital leadership actually give that group the authority to make the decision. That's a key concept that we may talk about further as we go along. But Stephen, I'll throw it back to you.
That was a great introduction, and I appreciate you mentioning all those points. So I'd really like to talk about why it's so important to build that effective PEC for surgical governance. And before we get too far down that wormhole, can we talk about who should be on the PEC? You mentioned it was administrative. Is it only administrators that are on this PEC, or do we want some clinicians on it, or what's a good mix?
We do definitely need clinicians within this body to more effectively make decisions. And we like to think the key membership of the PEC are really 4 members, although often there may be additional ad hoc members that come from time to time. Those 4 key members start with the department director, who carries the responsibility of working with all of us in the trenches in the delivery of that patient care. So the department director for perioperative services, a key leader that comes to the table. We also want involvement of surgeons and anesthesia, and at least one surgeon and one anesthesiologist that is representing their specialties, but also engaging in administrative work on these decisions regarding resources. So there's a surgeon perioperative operations director and also one from anesthesia. The 4th element then is to bring back in senior leadership within the organization, and we usually ask for a C-suite leader, if you will, that has the responsibilities over perioperative services. And so that person brings in a better understanding of the strategic plans of the organizations, their objectives, and we then are ensured that the operational decisions that are made by the PEC are in alignment with that strategic plan. Oftentimes when we studied that, when committees similar to this were given responsibility like the old OR committee model, the problem was they weren't given the full level of authority and they weren't necessarily making decisions that were in alignment with the strategic plan of the organization. That was one of the elements that actually got in the way of us to be able to change the care that we wanted to change. So with the PEC, we've got all the right players at the table, and the PEC invites in ad hoc members such as the vice president of supply chain, the C-suite leader over ambulatory care planning or strategic planning. They all are invited in and can participate in the decisions that are being made by the PEC. But the PEC is the core element, not only to get those decisions made, but then to follow up with the action plans to implement and ensure that we get the things done that we wanted to. So very often as a staff member and a budding manager, we seem like we never heard the final decision and we never really changed anything, even though we had multiple committee meetings that we were attending. So the PEC, if you will, is that stopgap. It's that single source that will be responsible to ensure those things that we want to have happen to improve patient care can in fact happen.
And that's super important for what we do. I'd like to talk about the members of the PEC a little bit. You mentioned that there's 4 core members. Your C-suite representative, who in theory is used to making administrative decisions. Your periop director, who also is familiar with making administrative decisions. And then the other 2, your anesthesia operations director and your surgery operations director, a surgeon and an anesthesiologist. What are some things we look for as we start to assemble those PEC candidates? A lot of the surgeons that we come across and the anesthesiologists that we come across spent years in medical school to conduct medicine. And now we're asking them to take an administrative role or to take a more administrative role in addition to their surgical duties. How do we identify viable candidates that are both incredible clinicians as well as willing to make those administrative decisions and provide those insights outside of an OR?
Good question. And indeed, we're looking for a surgeon and anesthesiologist that is respected clinically for the work that they do. They're also respected in the sense of being able to collaborate with their colleagues, but they also need to have a transition in their mindset of how we go about the management process. So good management processes need to be embraced by the physicians that we bring on board to an executive committee such as this. To put it in simple terms, we all work and want to move fast. And so we work with other physicians and even nursing staff that see something and say, let's just implement it. This is the right solution, utilizing that good management process, which isn't terribly difficult for clinicians if they relate that to their clinical decision-making process in patient care. But making that transition over from a single person making a decision to a group process is what we look for.
So these physicians that we're looking to bring up on this management process, do you have any experience in coaching these physicians? Because I feel like a lot of what at least I've done in my implementation experience, in addition to managing the change that an organization is conducting, is really helping coach and advise the organizational leaders on how to manage these changes and how to make that second and third step decision making process, looking at secondary impacts of whatever decisions they make. Do you have any experience coaching these operations director positions on how to conduct that role successfully?
Yeah, that was one of the things that we identified also early on in developing a good solid governance group was the people that become involved with governance need to understand all aspects and all dynamics, if you will, of the surgical services environment. I think surgeons and anesthesia see things in a pretty good way, but they also see things with a focus of, I'm primarily a surgeon. I'm thinking of the time I'm with that patient, whether the short time in pre and post-op I'm with that patient or the longer time intraoperatively, but I'm still narrowing my focus to just those periods of when I am actually in the operating room. Anesthesia in a similar manner goes through the same thing in terms of they're interacting with patients primarily around anesthesia care. So both need to learn a bit more about all of the clinical support processes, perhaps a lot more about nursing and nursing support positions and down to sterile processing, supply chain, and all those elements that contribute to what the surgeon and anesthesiologist experiences every day. So some time spent around that is a well-invested time. And I might mention the same thing applies to administrators. So from an administrator standpoint, I remember some years back in my career, many of the administrators that I worked with reflected on, Jerry, I've learned so much about surgical services, and you need to be aware that most administrators don't have an access to this level of information or exposure to surgical services in their training and their prior backgrounds. So I took that up actually as a challenge and ended up co-authoring a book, which is an introductory book for healthcare executives and physicians who are placed in administrative roles over perioperative services, but may not understand of all the dynamics that are in place.
I'm glad you mentioned that, because if you didn't mention the fact that you were a published author, I was certainly going to. And that was one of the first things, your book was one of the first things I read when coming on board at Sullivan, and it was incredibly helpful for that perspective. And I'm really happy that you brought up sterile processing, because I feel like of all the departments within perioperative services, sterile processing is either completely forgotten or only thought of when something goes off kilter with it. So I think it's incredibly important to consider sterile processing when you're doing things such as moving volume from one location to another, or trying to increase your large set volume, whether it's orthopedics or robotics. Sterile processing is such an incredible department, and how they work and how they manage and the people that work there, that I really like to bring a lot of positive attention to them, because they do so much for a facility and are oftentimes maybe neglected in conversation. So I appreciate you bringing that up. Looking back at the organizational structure of a PEC, in my history, the first thing we really want to do is, when you're standing up a group like that, you need to define its positions, its roles, its responsibility, and how it functions, which typically starts with a charter, as many of our groups and committees do. What are some elements that are important to have in that charter as we're standing that group up?
I think what comes to mind in terms of the critical elements are that we're ensuring, as I mentioned earlier, that the group's scope and responsibilities are clearly defined. So when we think about surgical services and we talk about the different units that support it, we like to believe that all aspects of the care that is needed for patients that are experiencing an operation or a procedure procedure need to be included within the scope of this group. So we can definitely think of the operating room areas. Really, what is very, very important is to ensure that we look at the continuum of care. So if you can think of a central body of this PEC that's given this scope of responsibilities, they would be reaching out to all other departments within the hospital that also touch or support that perioperative care, but it may not be directly aligned in periop services. These would be things like IT, information technology. Management of the electronic medical record is so very important for the efficiencies we have within the operating room. The pharmacy director, the materials manager, supply chain elements within the organization. So we realign those departments to understand that the work they do and the way it affects perioperative services needs to be brought to the PEC by these departments and discussed, especially if they're considering a change, so that the PEC can help and ensure that the implementation of these changes goes smoothly within the department. And the last I mentioned, it was pretty significant. I'm going to come back to that in a little more detail now. Does this group really have the authority? Can they, in fact, make decisions that will stand up in the organization and be able to be implemented? I mentioned it's very, very important that the senior executive team actually go through a transition where the senior executives no longer are making decisions unilaterally about the care within patients in the operating room. We've all heard the stories, those of us that work in perioperative services, of, let's say, a surgeon that is unhappy with the delivery of care within the area, bypasses all managers and directors and goes right to the CEO of the hospital to voice their concerns. And those good CEOs want to respond to these concerns and may make quicker decisions on the fly that may not align best with the management of resources within the department. So a key element is working with the senior executives so that they understand to purposely redirect complaints that they may hear or concerns that they hear, or if they're understanding growth of a program, that it gets directed into the PEC so they're aware of it and can act on it appropriately. So that's what I'm talking about in terms of authority level. And again, it's very important that the PEC understands the strategic plan of the organization. When we pull these things together in this manner, then the PEC becomes very strong and actually is very effective at better management and changing the processes within perioperative services in alignment with all those things that I've just talked about.
And I think a major line of your context there was that, yes, the PEC is small and nimble and able to make decisions because it's ideally 4 people. But it's not just those 4 people operating behind a closed door. There's a multitude of ad hoc opportunities for insights, and we encourage that from the sounds of it. So it's not just these 4 individuals making the decisions. They're getting their input from their data experts. They're adding ad hoc members from specific service lines. They're talking to different departments in periop services. So it's not just these 4 hammering through decisions without external input. And I think that's going to be something that's super important as far as decision-making structures go. And then while we're talking about decision-making structures, how have you in the past coached organizations that are maybe so risk averse to the point they become stagnant and don't make a decision? How have you looked at an organization previously and said your lack of decision making, whether it's in totality or decision-making pace, is hindering the performance you could be experiencing in your periop services?
Well, there's always time-honored methodologies that can be used to make an organization more comfortable with making a difficult decision that may be very impactful throughout the organization. The one that most often comes to mind is the sense of pilots or trials. So when we put together committees, I'll call them performance improvement committees or task forces that work on a problem, and we arrive at, here's a decision we'd like to make based on that PI's group's effort, but it sounds risky, then we can certainly introduce it in a small manner, in a pilot or a trial manner, to test whether or not we get the outcomes that we need. So when I say testing outcomes, I think that brings up a very, very important point. The PEC is a data-driven body, so it needs to maintain and build a set of performance and quality and financial metrics that actually look at the outcomes of surgery, measure them very closely so that as we make decisions to change processes, we can track those outcomes and see if we have actually achieved what we set out to achieve. So I don't want to minimize the data-driven aspect of the PEC. So very, very important that we make sure that we are measuring those effects. You know, Stephen, you mentioned one thing here that I want to come back to, and that I thought you were going to hint on it, but there's another body that's part of these governance structures
I was getting there.
that is so very, very important. So for a real effective PEC, they need to maintain a balance with surgeons and surgeons in the community. And so we very, very often, in addition to starting the PEC, develop what we call a surgeon advisory group. Now, the surgeon advisory group is a small group of physicians, and maybe 8 to 12 surgeons, depending on the size of your organization. It represents the multiple specialties that work within surgery and procedural areas, and also encompasses, if you've got an employed or an independent model, the right mix of those types of surgeons within this body. What this body does is it serves, as the title suggests, as an advisory body to the PEC. So the PEC can work with the surgeons in confirming problems that they see in the delivery of patient care, work those issues by way of forming performance improvement task forces and other studies, and then when a solution has been arrived at, run that solution past the surgeon advisory group. It's not asking for their permission, but it's asking, is this going to get the impact we want? And also, what's most important, how will this impact surgeon practices? So when we go to roll it out or implement it, we've got all of the surgeons in alignment. So that surgeon advisory group plays an advisory role to the PEC, but then also goes out to the surgeon community as members of the surgeon community to put the word out, if you would. This is what we were trying to solve. This is what we're going to do, and garner support for the changes that will happen that will be affecting surgeons and surgeon practices.
I'm glad you mentioned that. That's a great point. And then I want to jump back real quick. And when we're talking about risk and risk aversion, at no point will we recommend anything that would increase risk for our patient. What we're talking about is organizational and operational risk, and never towards patient safety. So just as we're commenting on risk aversion in organizations, I want to make that really clear that we're never talking about acceptable risk to patient and patient care. But I'm glad you brought up the surgeon advisory groups. As we're looking at implementing this type of governance model with a client, is there a one-size-fits-all solution, or do you occasionally find yourself tailoring your approach or your members to a specific organization's wants or needs? Like in some organizations, we may have seen that they want anesthesia present at this surgeon or surgery advisory group. Some organizations, they may want to keep it strictly surgeons. What's your experience with that?
So I think the governance model that we've been talking about, the Perioperative Executive Committee, this surgeon advisory group, and how they interact all throughout the department, inclusive of anesthesia, I want to mention is very malleable in its implementation. So there's no rigid model, but the fundamental principles that we have talked about related to responsibility, authority, accountability to ensure things are going to happen. Those are core elements that remain the same regardless of the size or the type of governance structure that you put into place. Anesthesia services is absolutely a key element in providing the patient care. They need to be represented both at the Perioperative Executive Committee level and beyond, and whether we're including them in the performance improvement task forces that we're going to be establishing, or whether or not we elect to have them a member of the surgeon advisory group. I think the tipping point often is just how well we can bring surgeons and anesthesia together to be a collaborative and working body. So if we start in an organization where that collaboration just isn't in place, and we want to launch the executive committee, this governance model, very quickly, then we may make a few compromises and say, okay, let's start the surgeon advisory group as an example without an anesthesia representation, so they feel comfortable in that setting, speaking to where they would like to see anesthesia services improve. I think that's a short-term and a very good goal to get the surgeon advisory group up and running, and then we work very hard on that relationship of anesthesia services and surgeons through the PI task forces and other engagement. Very, very often then we've got an anesthesiology anesthesiologist or two, or perhaps a CRNA, ultimately sitting on that advisory group, because that's when they come together. You can just imagine how that matures for people to be very, very comfortable in a room, to be able to speak to the right collaboration around making decisions in terms of how best to improve patient care within these areas. It also applies a bit differently for the larger or the smaller organizations. So when we think about the governance model for an academic medical center, we have to think about how we're going to engage the chairman and the chiefs of their respective surgical departments. They are very, very busy folks in the jobs that they have, and often they may not be the right representatives to go to the surgeon advisory group, which is going to require time off of their schedules, but rather disseminate that to leading surgeons within their different departments to sit on that surgeon advisory group. So a little bit different approach, if you would, on the academic side. And oftentimes we build a direct communication link into what we call our chairs and chiefs of surgery, so that they are actually following along without feeling they need to be in the room for when decisions are made, and going about implementing. Now, if we kind of moved all the way over to the other side to smaller community hospitals, they don't have a lot of surgeons necessarily on staff. And so we look to how do we conserve the demand of meeting time on those surgeons? So again, using that same surgeon advisory group as an example, we just may make it part of the Department of Surgery meetings that they have, so there's not additional meetings that surgeons would need to attend to. But fundamentally, again, what are we doing? We're saying we need to engage the surgeon community such that they have an advisory capacity into that executive committee, but also respect the executive committee when a decision is made and participate fully in the implementation of that change.
I'm glad you brought up the facility size difference as well. So thanks for covering that. As we're working towards wrapping this podcast episode up, I want to talk about what are some signs for an organization that they may need a governance restructure or a governance pulse check. What do you recommend an organization look for to start considering their governance structure as a challenge?
Yeah, I think I hinted early on in the podcast that I've experienced this many times over and over in different organizations that I've worked in, that they feel frozen, that we've got some good ideas and we want to implement them, but they never get done. And we form a committee that takes a look at the problem. They come up with a good plan, and we charge out to implement it and find that we either can't implement it or we never really get to the point where we've resolved the problem that we're talking about. If I, as a staff member, and we didn't talk enough about staff and the engagement with executive committees, because they are engaged in similar...
Sounds like a good episode.
Yeah, and they are engaged in similar manners with that PEC, if you would. But staff physicians, when they say typically, I don't even know who's running the department. I don't know who to go to, so I have to run into that CEO's office or the COO's office because I don't know who's running the program. And so when you hear that from staff or physicians within the area, it gives you some inkling into, do I have the right governance structure that's well understood throughout all the care providers within the organization?
That's a great point. And we mentioned it earlier, your book, where's the best place for people to find that? Just in case they want to do some brushing up from that executive perspective.
So there are two sources, that I would talk about. Certainly there's the publisher of the book. They would appreciate that I mentioned them, and that's Sigma Theta Tau. So Sigma Theta Tau were gracious enough to sponsor myself and another author in writing the book. The name of the book is The Healthcare Executive's Guide to Navigating the Surgical Suite. So you could find that at Sigma Theta Tau, and you can also find it at many of the other sites, the book sites that we normally go to. Amazon, as an example, I know is a source, but many that you may be using already would also have access to the book.
Great. All right, Gerry, thanks for your time today. I'm looking forward to getting this episode out and really looking forward to seeing, if we hear from organizations that are able to relate to some of the challenges we've talked to here. If you have any questions as a listener for anything on this podcast or services we provide as a company, please reach out to us at podcast@sullivanhealthcareconsulting.com, and you'll hear right back from us. Thanks for making it this far in the podcast, and I'm looking forward to getting you back on here for some different episodes, Gerry. Thank you for your time.
Thank you as well, Stephen.